to get in. You are on our AB 1400 CalCare office hours. We're going to launch into our regular program at 5:05. People joining us here on Zoom, people joining us on Facebook. Welcome to everybody. We'll be checking for questions both on Facebook and here on Zoom. That's what this is about. Welcome, Denise and Paul. Nice to see you. Welcome, Steve. Welcome back, Steve.
Is Jeanna going to be here too?
Not this week. She's on a true vacation. But the nurse and the doctor are in.
All right. So
Maureen Cruz
Yay.
is going to be our.
Oh my goodness, we're triplets.
Co-host. We'll get going formally in a minute. If you're joining us, we'll start in a minute. Welcome to everybody who's on Facebook and joining us here on Zoom. This is going to be a Mother's Day edition, by the way. So it's 5:05. Let's go. Welcome, everybody. This is AB 1400, Guaranteed Healthcare for All Weekly Office Hours, which is a joint production of Healthcare for All Los Angeles and Physicians for a National Health Program, the Southern California chapter of that organization. What is AB 1400? Well, we're going to find out in detail in a second, but it is a bill that was introduced into our legislature in February that, if passed and a few other good things happen with that, would give us a whole new healthcare system in California that would take care of everybody. We're going to hear about that. So then what are office hours about? Well, office hours is a place to talk about that bill. And for people to who are new to the whole idea of single payer in a state or single payer universal healthcare, to hear about what that means, to learn about and to ask questions and answer questions about that bill and how it would transform things in the state of California. We have people here on Zoom, we have people on Facebook, and we'll be monitoring both for questions. So I do want to do a couple introductions. So first, I'm Ron Birnbaum. I'm a doctor in Los Angeles and an advocate for this kind of change. And we have a first-time co-host, but a long-term committed champion of healthcare justice in Los Angeles and California, who is a public health nurse who now focuses on almost entirely on activism, named Maureen Cruz. So I want to give a big warm welcome to Maureen.
Thank you. And it's long-term, as in I'm almost ready for long-term care. Okay.
Hear about that.
So
This is
fast.
fantastic. And by the way, this is, oh, here comes Carol. This is a special Mother's Day edition of CalCare office hours. So we mean something substantive about that. But to take us through the sort of the next step, which is to really just hear some basics about what is this bill. I'm going to turn it over to Maureen. And do you want to share what you have, or do you want me to share that thing?
Yeah, why don't you share it since you.
Sure, thanks. I had it queued up. Yeah. So let's see.
There we go.
Here we go.
Okay. The folks that I see on this call are probably pretty familiar with this, but it's always good to review things before we get started. And these are the basic principles of CalCare AB 1400. And of course, it is the solution to our broken healthcare system, because it is a single payer universal healthcare system that regards healthcare as a human right. So universal coverage is the very first principle, and that, as we know, is everybody in, everybody out, regardless of race, sex, gender, country of origin, disability status, immigration, marital age, income, and everyone gets the care, gets equal care, regardless of ability to pay. Single payer program means that it is a publicly funded program which is paid for through progressive taxation to cover all necessary care in California. It eliminates the billions in bloat and wasteful administrative spending, and just also the profit taking. And this saves us really billions of dollars in healthcare costs that we can apply to the delivery of services. CalCare guarantees fully comprehensive benefits. So medical, dental, hearing, vision, mental health, prescription drugs, long-term care, and more, all of those things that we are being deprived of now, despite the fact that the public is paying 71% of all the costs. So all decisions about what benefits are applied to any individual person, any individual situation, those decisions will be between the patient and the doctors and nurses, not insurance companies. Removes insurance companies from the equation. CalCare guarantees freedom to choose our care providers. So under CalCare, there's no more network, no in-network, out-of-network. We have the freedom to choose any doctor, any hospital, any provider that we like. And that will guarantee that instead of a race to the bottom for how much money can be extracted from a system away from patient care, the metric will be who can give the best care. People will have a choice. They can go to the place where they feel that their needs are being met. Free at the point of service. No more co-pays, premiums, no deductibles. You arrive at the doctor's office, you show your CalCare card, you get the care you need. It's that simple. And this is very important because even small co-pays are deterrents to people getting care. So in order to have equal care, that a separate is never equal. So financial status separates us. So we want to remove that barrier to care. Just transition, and that is for those folks who will be losing their jobs in an insurance system, that there will be some funding and some programs to protect and support them. Any displaced workers in the insurance industry, they will have support through this bill. Patient care will be based on patient need. No more financial incentives to avoid providing unnecessary care, or to avoid providing necessary care, including value-based payment models for providers. It will also cut down on unnecessary care that is also can be a problem in our system. In the system we have now, if it makes money to deny people care, it will be denied. It makes money to give people care that maybe they don't need, treatments maybe they don't need, that those treatments will be given. So we need to remove the profit incentive and put both the health and the care back into the system. And that's CalCare, AB 1400.
no, thank you for that, that great introduction, and very well done. But as I said in the intro, today is of course Mother's Day, and so we thought, let me say this. Usually with office hours, mostly we want to go with people's questions driving our conversation. We're going to go from now till 7 p.m. And because what's on people's minds, their questions are core. But we often want to get going with like a little subtopic, because healthcare is a big topic. And the bill is, it's 40 some odd pages, and it goes over a lot of details about how all this would work. But one question you could ask is, what does this bill do for mothers? How is our current system and serving mothers poorly, and how could it be much better under this new system? So one area is the question of our older mothers and long-term care. So Maureen, what's the deal with long-term care and CalCare?
Well, currently, long-term care is not included in our health insurance system unless you pay for it privately out of pocket. In order to get that care, if you're not able to pay for it out of pocket, a person has to spend down their resources down to the point of Medi-Cal. So right away, you have people like myself who have our homes and any savings that we were able to accumulate throughout our decades of work. We have that for our children, and people have to lose that. That's really difficult, because for many people that is your self-worth. Your total worth that you have to offer to your kids. I remember sitting with a group of people at a table, most of them mothers, actually. It was a women's group. And these were women that were refusing to go on to the to Medi-Cal. And the reason was they didn't want to lose their homes. They didn't want to lose their homes so that there would be nothing left for their kids. The other problem with long-term care we know now is that the facilities are woefully underregulated. The inspections are not adequate. We know that people that go into long-term care facilities, they have a lower life expectancy than those who are cared for at home by family members, but family members aren't able to do that. The majority of those taking care of parents are women, are mothers themselves, caught between caring for their children, maybe even their grandchildren, and also their parents. And that's a really untenable situation. So what CalCare does, it institutes long-term care as a benefit, a guaranteed benefit in our healthcare system. So that includes nursing services for a member, whether it's in an institution or at home. And that's very important because we haven't been able to be taken care of at home. Most people, in order to get the care that they need, have to go to an institution. My own situation was I experienced both of those. My mother, because of the kind of insurance that she had, both my parents were teachers, both of them were high school teachers. My mother was her benefit from her district allowed her to stay home and get in-home care. My father, also a teacher in a neighboring school district, was not able to do that. So my father had to go to an institution, to a nursing facility, and my mother had to pay out of pocket about $3,000 a month. I'm sure it's more than that now, because this was in 2001, actually, that it was $3,000 a month, which depletes, an elderly person's savings. And So we don't want to have those differences, those disparities anymore. We want everyone to be able to get the care that they need and not have to impoverish themselves to do so. We know now that the things that seniors need are not covered. We need everything from the neck up that we're not getting, okay? Dental, hearing, vision, mental health, those things are missing from our health insurance system that we have now. So those will be included, all necessary care for our health and our well-being. Also things like canes and walkers and even wheelchairs in some cases, our people have to pay for those things out of pocket. And we want to end that stripping down of people's finances in order to cover things that they absolutely must have to live. CalCare prioritizes the delivery of long-term services in the home, but it doesn't mandate that. If a person chooses, it gives you choice to have your care, your long-term care at home or in an institution, in a facility, but it is a choice. And right now, people really don't have that choice. Adi Barkan is probably the most famous person who has highlighted the fact that he has to raise money in order to be cared for at home, to stay with his wife and his son in the years that he has left to him. So that's just a tragedy that someone has to raise that kind of money in order not to be institutionalized. It seems almost really like an 18th century, something out of, or 19th century, something out of Dickens. So, so the least restrictive environment is kind of the qualifier for the kind of care that people can have. We want seniors and people with disabilities to maintain our independence as much as possible and to have lived the last several years of our lives with some dignity. I'm trying to see. So there will be, in CalCare, there's an advisory commission, and that is 11 people in the Long-Term Care Services and Supports Commission, and they will make sure that the services and the benefits are provided. They will review what is needed, if anything else more is needed, or review how the program is working for seniors in long-term care. So that's about it. I think how many people on this call, although those of you that are, we can see, how many of you have been, have cared for your elderly parents at all? Oh, okay. Or been responsible for figuring out how they get their care, right? Quite a few. So there you go.
No, that's wonderful to explain that. Although the system we have in place is terrible and is really, not what. I mean, we could just do so much better.
Well, COVID has shown us, because the very high rate of deaths of people in nursing homes. But people in nursing homes have been suffering really poor care for a very, very long time. They're very poorly regulated. We once had a speaker come and talk to us. She was an inspector for nursing care facilities. There were about 300 in the county at that time. There were 3 inspectors for 300 facilities. She had 100 facilities, and she said every facility had multiple violations of protocols and of protective measures for the residents of these facilities. And she said she couldn't possibly get to them all. And it was really very stressful for her to realize all the need and how it wasn't being addressed. Another issue, LA Times recently had an article about nursing homes in the county of Los Angeles. It's a business. This is not healthcare. This is a business. Anybody can open one. Anybody can open a nursing care facility. And they when several violations are finally logged and they are removed, say from providing care, after 6 months, they can get back into business again. It's only 6 months, and then they can start right back up again. So it's an underregulated system. It's a system that is underfunded. The workers are low-paid workers. There are not enough. The patient to care worker ratio is really, untenable. Another thing's been happening because these are so profitable is that there's a lot of private equity investment in these nursing homes. And in examining what that means for patients, there was an important paper that was written that was about the private equity investment. And it said that private equity investment is associated with an increase in mortality, especially for short stay Medicare patients, an increase in taxpayer spending, a decrease in nurse availability, a decrease in compliance with Medicare standards of care, and an increase in operating costs that tend to drive profits for private equity funds. So the priority is on the business interests, not the patients. So we need to take the business out of healthcare, put the care back in, and put health as the primary focus, not extraction of profits from the system.
Thank you. And another angle on this before we just go to our open questions is we've got issues of moms later times in their life. But what about moms when they're deciding to have kids or not deciding whether to be moms? And so if you, in the bill in AB 1400, there's a list of all the mandated services that are part of, they're just what the benefits are. And they're better than most insurance companies, not most, all essentially, and better than certainly than Medicare, and certainly better than Medi-Cal. And but there is a single line item that I want to point out. Its significance, and it's only 6 words, but 1, 2, 3, 4, 6 words, which is that the benefit it gives comprehensive reproductive, maternity, and newborn care. And included in the idea of comprehensive reproductive care is things like paying for things like abortions, because one thing that may make a mom the best mom she can be is having a baby when she thinks it's the right time to have a baby. That should be up to her. But we have a system that doesn't at all guarantee that. As it may be somewhat guaranteed by the constitutional right, but that doesn't mean there's resources behind that right. So what does that mean? And you hear all the time, these kind of like political struggles back and forth in Washington, et cetera, about the funding of Planned Parenthood and the defunding of Planned Parenthood, and a new government comes in Washington and they don't want to fund Planned Parenthood. And well, what if you just gave every single woman a comprehensive health plan that paid for that? That just, we'll never have to worry again about the funding of Planned Parenthood, right? So these are ways to honor moms, or people who want to be moms, or people who don't want to be moms. And so let me leave it there for our big Mother's Day thematics, and open things up for questions. Or do you have
I wanted to add, maternal health is probably one of the worst areas of care that we have in an insurance system. We are actually ranked 76 in the world for quality of maternal health care. We are behind 75 other countries. We have a very high rate of infant mortality and also maternal mortality, morbidity and mortality. And yet we spend 2.5 times more than any country in the world. The racial disparities are enormous. in maternal health. We see that moms of color have much less access to care, and the care that they get isn't the best quality. And that's why we need a system where we are all equal, everybody the same, because separate care is never equal care. We all need the same care. So maternal health is very, very important. One of the things that CalCare would do, there are a lot of things that AB 1400 would do that are sort of tangential, but I think would be a consequence of getting guaranteed healthcare as a human right. And one of those is the type of care that we would be able to get. There's quite a bit of research out there right now that doulas and midwives actually have much better rates for maternal health and maternal and infant health. And they would be more accessible. We could definitely stress that and stress the ability of hospitals and also in-home care to accommodate having midwives and doulas. And especially that's when we talk about the need for cultural competency, we want people to be comfortable with their caregivers. And especially a mother having a child needs to feel full confidence that the people that are caring for her are really understand her. And we need linguistic competence. We need cultural and community competence, and allowing a system to expand on having doulas and having midwives care for patients would do a couple of things. It would, I think, provide that kind of comfort to new mothers, but it would also relieve hospitals of the more expensive care of having somebody come to a hospital and be in a hospital room when it's not necessary. We could leave those that option for people who are at risk in some way or who are more comfortable going to hospital. But right now, if a person wants to receive care at home, has to be out of pocket. So we need to expand our modalities of care to accommodate for cultural competency and the comfort of the patient.
So let's go to some questions. There's a couple in the chat. So maybe I'll do one from the chat, and then are there actually Paul, are you keeping an eye, as you sometimes have, on Facebook?
Yeah, I was just there, just trying to spread it to groups that HCA is involved with, let's see. I don't know. I just put a bunch of them. I'm sharing them to a bunch so we can get some groups to see it too.
Super. Well, so if you'll let me know, or if or put something in the chat or whatever, if you can, or I'll check with you.
Sure.
But first, let's start with. I mean, do you want to just state your question? Yeah, go ahead.
All right. What's going on is I was at the PDA Emergency Healthcare with Bill Honig, and some woman spouted out all these roadblocks, problems with Medicare for all, and like the idea of having states handle it, and getting the waiver and all this red tape that's just ridiculous, and also the Supreme Court, and then I thought about Taiwan, Denmark, Canada. Taiwan, by the way, took the best of all healthcares and created their own healthcare system, single payer system. That's probably one of the best in the world. Yeah. And, it's such an easy thing, and all they want to do is complicate it. And it's obvious that, the private industries almost have a stranglehold, on us. And the question is in California, I've decided, I was at a rally yesterday, and I got, I don't know if you could see it. Wait, let me see if I can get this out of the way. Can you, it's hard to show these. I got the basically the same chart, the first chart that Maureen showed, it's in a flyer, and I passed them out, and I'm thinking about making some flyers and everything, door hangers and things like that. But it just, astounds me that there's the power of, you know, you go up to an assemblyman or a state senator, like someone like Ben Allen, who claims to be a progressive, and tell them about this. And, you know, it's so simple. It really is simple, and it's not a big deal. Everything is taken care of in this bill, AB 1400. But yet they resist, they continue to resist, and they're not representing us. And I think, you know, we've got to be a loudspeaker and call them on it.
Well, tell me, can you give it, like, it seemed like there was a couple of questions in your question. So one is like the ability of other countries to do this.
Yeah, so quickly.
And you gave an example of one. So in other words, is there something different between a state and a country, maybe?
Well, yeah, they have provinces or states too, but
right. And in Canada, it was started in one province.
Right, it started in a province and then took off. Right. You know, like what we're trying to do, and what Washington's trying to do, Washington State, and so forth with their bill too. They have a bill also, but to me,
New York State right now on the precipice.
Go ahead, Maureen. I didn't hear you.
I just said, and New York State is also on the precipice of.
You know, I mean, this is such an easy thing. It isn't as hard, and they're just, you know, they're kicking and screaming, and I just don't understand how it, you know, it's a problematic situation we're in this country and in our state.
Well, I mean, when you say easy, let me say that I think it is easily clear that universal healthcare systems that are publicly funded cost less and deliver better results. And that's pretty much just fact. That there's sort of the facts as in multiple studies. So maybe you're saying like, well, what's so hard? So I would say that there's two things maybe that are hard. One is that this does represent a big change from the way we're currently doing business. And it does represent a big chunk of the economy changing how it's structured. And so that maybe explains at least what people are saying when they say that it's hard. And then the other thing it seems like you're talking about is, the other thing is the way that American healthcare works, which, and Maureen pointed this out, 71% or something like that of healthcare is already paid for by public sources. But that's a mixture of state and federal sources and also money that comes from the private sector. So to put all that together in one pot for a state requires passing a bill and passing a tax program and also bringing in federal monies through systems of waivers of federal healthcare law that allow the state to appropriate that. So right. those are doable. I mean, I guess we could debate about what the word easy means, but I think it may be what, I think also one thing you may be encountering is that when people don't want to do something, then they find ways to kind of describe how hard it is. But I hope maybe that answers that question. I saw there's another question and that I saw in the chat from Alberto Saavedra. Hi, I mean, it's a pretty simple question, but do you want to just read your question? Nice to see you, by the way.
I was just curious about what government organization regulates nursing homes. I don't know anything about the subject matter. Maybe one day I'll end up in a nursing home. So I'm curious about what is the structure of that industry now vis-a-vis the government.
I can say some of the things with you. Maureen, you hit a couple things like indirectly, but maybe directly. Do you want to take some of that and I can add in anything I know? I don't know everything.
You know what? I honestly would have to go back and I haven't looked at it in so long, but it was Department of Health Services, DHS. And then there's also the department that handles Medicaid for people that are on Medicaid. Medi-Cal is Medicaid.
But there's no clear organization that's...
Yeah, there is, and the county is actually responsible for doing the inspections, and but the state is responsible for granting the the licenses and allowing them to operate as a business. So
the county is the front lines.
Yes, the county. So the DPSS in LA County does this. In fact, I think that was the person you were saying who worked doing those inspections would have worked for DPSS, Department of Public Services and Support, something like that. They employ, like, for example, the workers who do some of this stuff. And actually today I was working doing vaccination with somebody who done that same job. And she was telling me exactly what Maureen's person she talked to said, which is that they're both incredibly overwhelmed. They can't, they know there's a whole bunch more that's going wrong than they can even begin to intervene on. And so, but let's take a step back and think about that and in relation to the bill. So when you have it in the current like long-term care arrangements, there are, as Maureen was saying, a whole bunch of for-profit operations. And for-profit operations, as far as care like this goes, and a lot of other types of care, are in an inherently conflicted position related to the care of the people they take care of, right? In other words, if they can cut back on that, on this money they spend on that care, they're going to make more money. And actually, this person who I talked to, who was an inspector and who felt, I think, almost like morally injured by her inability to do that job well, she was telling me that how often she would try to talk to people who were taken care of in these settings, and that they were fearful to be forthcoming about the problems that they saw, because she was going to disappear, but the people who were taking care of them were not going to disappear. And so if you think about it, you could have a better regulatory system, but inherently there's an inherent ethical structure that's flawed in our long-term care system. And I want to say exactly how this bill would fix it, because it essentially, so a long-term care facility, and again, the bill emphasizes doing long-term care, also really doing it at homes more, doing it out in the community as a better choice. But to the extent that, and still certainly allows for institutions, but institutions under CalCare would become what are called institutional providers. They have to, they get paid in a very different way than they would be currently. They no longer would be paid in the sort of fee-for-service type way that institutions are paid now. They would be, they would be paid what are called through global budgets. And those global budgets don't build in, and they essentially can't take profit. Profit isn't budgeted into the global budget. So it would transform there would no longer be contractually eligible hospitals and long-term care facilities that could work for profit in California. That's a big way the bill changes that. So let's keep rolling with some questions. Is there?
Oh, I just wanted to tell Al, if you Google long-term care, you will get all the groups that are involved with it, all of the agencies. There's a Department of Healthcare Services, also the Department of Insurance is involved. Then there's the local, the county organization, the county administration. So it's kind of a weaving in of these different administrative agencies that have responsibility for different parts of the system. So this is one way that AB 1400 could really help the system, is to consolidate things. Right now it's fragmented, like everything in our system is fragmented, because we have so many different rules depending on if you're using insurance, if you're using Medicare, if you're using Medi-Cal, what kind of extra insurance you have. So
well, understand. I understand.
Yeah. So anyway, if you have a look, but what we do know is that 89% at least of the nursing care facilities are in violation of healthcare, various healthcare.
How many?
Especially infection control.
How many? What percentage?
89%. 89%.
I wonder about that. I wonder about that 9%.
Yeah. Family members of the nursing home owners. I don't know.
Maybe I should talk to the 9% to see what should be done with it.
But this one of the reasons we really need AB 1400. I mean, there's every reason for it, but you know, Paul's comment about things being complicated. There's nothing more complicated than the way we do things now. It's impossible to be more complicated
I agree
than what we have now. And what happens with complexity is that the care gets lost in the administrative functions, and we don't fund the functions approprihately.
No, I understand. I understand. There's only one thing that I have a difference with what Ron said. You know, I don't believe that profit is a useless tool. To the degree that providers comply with the rules that make sense imposed by the authorities, to have some competition among providers may not be a bad idea. And the metrics for that competition is profit. Of course, there's, you know, social media, there is, hopefully there will be whistleblower protection, all kinds of things. But, you know, I am not in principle against the concept of progressive capitalism.
So let me just respond to that. And as in, one could easily, these are kind of economic questions of policy, sort of political economy almost type questions. But I do just want to accurately describe what's in the bill, which is one of the main goals. And it is the case that so the bill would not outlaw a for-profit long-term care facility, but a for-profit long-term care facility couldn't contract with CalCare. And so and if you look at where most long-term care facilities get funded, some get private money, but a big number would get are paid by Medi-Cal. Because our current, Maureen kind of hit this, but our current system, I mean, there's some people who have independently saved up the enormous amount of money or were able to buy long-term care insurance, but that's not that many, not tons of people. So a lot of people, what they do is they retire, and then they're able maybe to care for themselves for a while, but when they move into a place of needing long-term care, and if they can't afford it, just paying for it out of pocket, then what happens is they go into the system that's publicly funded, which they have to steadily spend down their assets. And then Medi-Cal takes over completely once those assets are all gone. And so that system would get completely replaced, and CalCare would be paying for that. And there's nothing that says that you can't make a for-profit thing, but you would now be unable to care for most people.
You know, we have an example right now of one of the problems. Al, oh, you're muted, but anyway, I'm not, so I'm talking.
I
just wanted to give you an example right now. There's a big fight with Save Our Seniors is a project of the Progressive Asian Network for Action. What is happening there is a private equity firm, which owns dozens and dozens of these nursing homes, bought Sakura Gardens and some other, I think it's about four facilities that were owned and run by a Japanese company. And when Pana bought them, they wanted to evict some seniors so that they could sell part of the facilities and build something else there to make money. So this facility is primarily women in their 80s who've lived there a while. And there's nothing in the law that says they can't be evicted. Okay, nothing. So the fight is to get a law in place. So the point about, I think, AB 1400 and CalCare, we want guarantees. We don't want to be on the end of a hook like, you know, someone gonna buy this facility out and kick us out onto the street, right? Then you have to scramble and look for another place. And the other thing is when you're on Medi-Cal, on the lowest rung, you don't have choice. You're not going to have choice. There's not going to be like better care that you can choose your way out of. All right. That's why we need a system where the competition, there's competition, but it's for quality, because patients will be able to walk. They can go wherever they want.
I agree. There's just one principle that I'm struggling with. I thought AB 1400 was more a door opening legislation, as opposed to deciding exactly what happens on the other side of the door. Okay. I was just wondering if what makes sense now is to make sure that people understand that it's the principle that we want to move forward, not the details of how we're going to do it. Because I think that there's many other options in the details of how it's going to happen that could be very acceptable. I put on the table the concept of healthcare cooperatives. There is nonprofit organization law, there's corporate law, but in between there's cooperative law. And that is a structure that could be very, very interesting for providers.
Sure, but one of our, I mean, let me say a couple more things just about some things you said. So one is that in deciding whether this bill is something that makes sense to somebody, which I think it does. In deciding that, one doesn't need to decide whether one is a socialist or a progressive capitalist or an anything. But it's good to evaluate the bill just on what it says it would do. And it has an effect on insurance that really says that there's no multiplicity, like no insurance company can sell a product that duplicates the services in the state, the insured services. That's one.
I understand. I'm all for that. I mean,
there's another part that I want to explain, which is it does change. I mean, I'm trying to describe what's in the bill. For institutions that then sign on to CalCare, they can't really function as for-profit institutions. And then as a person deciding whether they think that's a good idea or a bad idea, I mean, I'll just give you, let's just switch to like another type of topic, like higher education. My personal opinion is that for-profit colleges suck. Like that it's a bad idea. Like I don't want to send my kid to a for-profit college. I just think there's too much conflict between what the college is trying to do to make its profits. And so in this sense, if this was a bill about what college was available, it would say CalCare is only going to contract with Stanford, a private university that's not for profit. It could contract with Cal, a public university that's not for profit, but it won't pay for you to go to University of Phoenix. It won't do that. That you have to decide if you, so anyhow, that's just what's in the bill. So
I wanted to add another layer to that, Al. 70% of the population now will eventually need some kind of long-term support services. And long-term support services as it is now is very expensive. The average lifetime cost per capita is $260,000. Okay, and we're not talking about medical care. We're talking about just support services for like activities of daily living and you know, just to get by, not exclusive of needing medical care. This often falls on children, right? People leave their jobs in order to care for their elderly parents or maybe an elderly sibling. 25% of children provide the caregiving in this country. And that's about $3 trillion in lost wages. It's a huge amount. The average savings for retirement savings for a senior is $148,000. So Medicare only covers short-term nursing and home health. So if you need anything long-term, you got to pay that out of pocket right now until you become impoverished, and then you will be on Medi-Cal, and then you will be in these facilities where you're really not going to have a lot of choice. And they're renowned for being in violation of very important regulations, especially around like infection control.
And it's hard to regulate them well. So I see Paul has his hand up. Paul, is that because you have a question or because are you seeing something is there anything in Facebook? We've done a couple of
the problem is it's not showing me all the, there's like 13 comments and I can only see 4 of them. When I try to look at them, that doesn't show me. So I just wanted to say that, but I wanted to comment about healthcare, the idea of healthcare, and how I was just curious. This bill, would you say it basically is establishing healthcare as the commons or the common good, like the Army's the common good, our roads are the common good, schools are the common good, our public schools, all these are the common good. When to privatize the common good is what we have now. We've done that, and it's a mess. And the thing is, AB 1400 provides it makes what it should be all along. Healthcare should be a common good, also known as the commons. Just like the roads we drive on, the police department and the fire department and all these other services that everybody, the masses use. You know, there are other things people can profit on, you know, selling to this, and that's a different thing. But the question is what is the better route?
So I'd take a shot at that, which is that of all the analogies that of like public goods kind of things, I would say for me, the closest one is highways. In other words, the purpose, we really have made a mistake in general in America, which is to like believe in insurance as the right, when really the right should be healthcare, right? Actual healthcare, guaranteed access to. That's why it's called the Guaranteed Healthcare for All Act. It's not a guarantee of health insurance, although you have that. It's about actually getting healthcare. And in that sense, I think it's more like the roads. In other words, and it is a public good, a common good. It's like the freeway, the highway system or roads. That's there for everybody. Everybody's allowed to use it. Nobody checks your papers if you're going to get on the road. And in this, but the destinations you can choose to go to are public or private, right? And so in other words, it doesn't, while with CalCare, for-profit institutions can't take CalCare money because of the way global budgets are done, it doesn't mean that Cedars-Sinai Hospital is taken over by the state of California, nor does it end LAC-USC Medical Center, a public hospital. It just says everybody who goes to either of those places, if they contract with CalCare, and they both would have what they need resource-wise to get their care paid for. So that's how that's the part that I think is the common good. In that sense, it's like the freeways more. Let's see.
Can I say something here? Thank you, Ron. I got to say, I just want to put this in here. Two of my proudest moments were when I met Tom Hartman, and the same thing happened. And in a moment with Lila Garrett, it was bothering me. This was a number of years ago when I was becoming involved in single payer, and made the point that both of them in their broadcasts were referring to unequal insurance, medical insurance, all about all these uninsured people. And I was so proud to make the point, it's not about insurance, it's about medical care. And a lot of the people are, at least in my practice, a lot of kids get care, they don't pay for it. At least that was my private practice. And, you know, the real issue is that we do a sustainable giving a sustainable system to keep giving care. And it's not about the health insurance. And I only bring that up because I think that's also kind of an elephant in the room, in that progressives have spent a number of years trying to give insurance to the disadvantaged. And I like that finally the focus is changing, that we need to really have a medical system that provides the care and take the people out of the middle.
Nancy, that's such a great point. In fact, healthcare and insurance are in complete opposition to one another. Insurance is a business, and in order to have a very successful insurance business, you need to make as much money as possible. How is that done? It's an extraction of money. It's done by charging as much as you can, giving as little as possible, squeezing providers, and consolidating and merging facilities so that you have complete control, and just shut down the units in a hospital that aren't profitable. And we see that now with emergency departments closing. That's been happening for 20, 25 years now. We see that with labor and delivery closing. St. Francis Hospital in Linwood was just taken over by a private, I think it was Health Corporations of America. I believe it was that one. And their labor and delivery services are at risk. They delivered more babies than any hospital in the entire state, about 5,000 a year. And they're at risk of losing that. Why? Because St. Francis has served the populations that live in those communities: Paramount, Cudahy, Linwood, Bell, Maywood. Those are the working poor. Those are those who are undocumented. Those are those who are uninsured. And those are those who have Medi-Cal. So we have the hospitals that are serving the people with the most need going bankrupt and out of business because of an insurance model. Healthcare, on the opposite end, is an investment. It's an investment of our dollars. It's an investment in the community. It's an investment in human beings. And that requires money put into the system. But money, as we see in so many areas, when money goes into a system to support people, it ends up really flowering into so many other economic advantages and so many other economic opportunities that make a community more vibrant. When you think about saving a hospital, you're saving everything. You're saving jobs, local jobs. You're saving everything around it. You're saving, you know, the cafes, you're saving the, you know, whatever facilities there are. You're saving vibrant small businesses all around a hospital. You're, you know, eyeglasses, hearing aids, whatever small businesses are around these hospitals to provide those needed items. So it's to have a successful insurance business, you've got to squeeze healthcare and deprive people of needed care. In order to have a successful healthcare system, you have to get rid of profit taking. There can be no profit taking. Every dime in the system needs to go back into provide the delivery of services. That's healthcare. So insurance, and I'm glad you brought that up because people confuse insurance. They've been trapped in this insurance swamp for a really long time, and they think insurance is healthcare. No, it's not. Insurance deprives people of quality healthcare.
But I got to say, from that moment that I talked to Tom Hartman, he never confused it on the air again, as far as I heard. And I was so
I didn't
proud
know
of
you
that.
schooled him. Thank you.
But it's a very good point because it's often a way the discussion gets fudged. They're like, yeah, I'm for covering everybody, like you, so maybe it's worth mentioning some ways that because there is a coverage, it's just there's one insurer, that's the state of California, and it covers everybody, but it has some features that are just different than kind of all the different health insurance things that are out there. It doesn't narrow the networks. It doesn't have all of those disincentives to utilization that are really big problems. And so, I mean, it doesn't have, and this is all this stuff that's just right in the bill. It doesn't have, it forbids prior authorizations. It ends co-payments, co-insurance, deductibles, all of these things, which are included are in features of things like Medicare. And so, these are, it's really different in that sense. It just sort of says the risk taking shouldn't be this financial product that's just sort of part of profit calculations. The risk should be taken by the commons, as Paul Newman said. That's where the risk should lie. And there's great strength in that. I want to mention, but I say Richard, I know had his hand up and has a question, but let me just mention a couple of comments that came from that Paul transmitted. Thank you, Paul, from Facebook. And maybe there's a little questions or discussions could be kind of made out of them. So Sean Broadbent writes, profit doesn't belong in healthcare. We need non-market solutions to create the guarantee. Market demands have no business in the needs of our people. And so we could ask, where is there any market, anything left or not left? Sin Tal, which maybe that's Sin's name, or is at least Facebook name, says this is something I work with families on a daily basis. Sin is referring, well, you'll see, patients needing long-term care and adult children scrambling, trying to figure out a plan. IHSS, which is individual health, in-home services and supports, is not a substitute. And it's only if they have MCAL, it's only if they have MCAL. The only option is to drain your assets, if you have any, and become a custodial MCAL patient. So that means you have no money left, and now it's MCAL's job to pay a nursing home to take care of you. That's what that means. When you don't have much of a choice in a facility, I feel useless at my job, parentheses, social worker, within this system. There are no options.
I want to thank Sintal for writing that. And to mention, Sin, you have a lot of company in dealing with a psychological issue that so many providers have. It's not really burnout, it's suffering from moral injury. It's suffering from knowing what your professional responsibility is and being denied the opportunity to actually practice your profession to help people. Being forced into a situation where you cannot give the care that you know is necessary. It's overwhelmingly depressing, and depression rates are skyrocketing among healthcare providers. More and more physicians and nurses are saying they want out. There's a lot of more early retirement. And it's not because the job is hard, because doctors people that go to medical school, they know what they're getting into. At least once they get out, they know what they're getting into. Right, Richard? And kind of, but in terms of dealing with people's pain, you're there to help people with their pain, help them navigate life-altering situations. Nurses understand that as well. It's not burnout. It's suffering from moral injury. Knowing, because you have a conscience, and knowing that you're not able to give what you want to give and what should be given. So thank you, Sintal. I see you're a social worker, so you too are a healthcare provider. And being on the front lines is no fun. Everyone on the front lines gets shot, okay? All right, I'm done. I think Richard had something to say.
Yeah, Richard. And then
So first and foremost, Sintal, like that, I totally empathize as a physician. You know, we have that type of sentiment all the time as well, because we also are limited as to what we can do for our patients because of the system that we have, this broken system that we have. So I certainly empathize with you, and you're not alone in that feeling that I can't do my job appropriately, properly, because of the system that's in place. You know, and I always refer to it as sort of a vicious cycle, right? Patients come into the hospital, you try to take care of them, and then the unfortunate part of it is that after that, there's no capability of follow-up. There's no capability of them going to getting the proper rehab that they deserve, all of those types of things. And then, you know, they don't get the proper care, and then they're back in the hospital again. And it's this vicious cycle that we see time and time and time again. So I definitely empathize with you. The other thing that I wanted to talk about was to piggyback on what Dr. Naparko said, and thank you so much, Dr. Naparko, for bringing that up, is that in addition to being able to deliver equitable care for our patients, which is very difficult in the state that we're in, because we have such disparities in terms of what coverage patients have. We're in this tiered system as it is. We have to be able to do equitable care without the risk of putting our patients and their family members into bankruptcy, right? I mean, it's just, it's sad, but you know, when we talk to patients after they're hospitalized and we say, these are the things that you need, but there's no potential for coverage of that, you know, and then they're saying, well, I'm not going to be able to pay for this. How do we recognize that? How do we rectify that? And I think that's one thing that CalCare did a very good job of, is they're recognizing that it's not just about the hospitalization. It's not just about having the patients come into the office. It's also about what do we do long-term? What can we do afterwards to ensure that our patients not only get healthy, but stay healthy? So those are the only comments I had. I didn't have any questions, but those were the comments I heard.
no, super. And Dr. Naparko.
Yeah, great.
I want
Great
to
comments.
add to Sintal. I really empathize as well. And I just Friday, a lovely mom and dad came in, boy doing some strange stuff. Probably a mom and I didn't exactly agree. I wouldn't agree with how urgent it was, but I said, you know, it's worthwhile getting an EEG. But I'm not sure, well, when will it get done? Well, it'll get done when your insurance approves it. And it depends on whether you have a PPO or what you have. And she became so furious, honest to God. I left work that day, sure that she's going to report me and maybe bring a lawsuit. I mean, it really was a simple thing of, I can't, because of all these different policies and such, and how long it takes to get approval, the patients get angry, and it may not be critical that he has an EEG right away. It's not, but convince a worried mother of that. And it's really hard to do our job when you don't know exactly what the system's going to do.
And that's part of the insurance business model, is to shift the risk to the provider, right? The risk of making a decision and then dealing with a patient who can't get what they need, right? It shifted to you. AB 1400 would get rid of that.
And another thing, piggybacking on what you said, one thing that just occurred to me for the first time, I think, is the inequity of healthcare would be helped, not just because everyone has access, but the access will improve and equalize as physicians' income is more fair across the board. I mean, right now, there's no end of orthopedic surgeons and neurosurgeons, and people feeding into them are limited. And if the primary care people, the cognitive specialties are paid a little more equitably, they're going to be out there. They're going to be available to the less advantaged.
You know, I'm so glad you brought up the primary care issue. There was just this month, the National Academies of Science and Engineering and Medicine, they released a paper and a plan. And they said that increasing primary care is a huge boost to increasing healthcare outcomes across the board. In Canada, primary care physicians have a lot more authority to order things. They look at everything a patient needs, right? And they can determine where you need to go next. They're kind of like your care coordinator for things that they are not able to do. One of the problems in this system, and I've experienced, and I bet everybody has if you stop and think about it, when you're a hammer, everything's a nail. So I have a relative that actually, it turns out her problem really is an allergy issue to progesterone, actually. It's a very strange kind of an unusual condition. But if you go to a dermatologist, it's all about just the skin. Go to a gynecologist, just about the hormone levels. You go to a endocrinologist, rheumatologist, dermatologist, when in fact it was an allergist, right? But first she had to go through all these things. I mean, she even had like a CT scan for possible pituitary tumor, okay? Because every single specialty had an array of diagnostic technology to apply to this patient. I knew someone else that had another woman who had an issue. It turned out to be just hormone imbalance, but she too went through a variety of diagnostic technologies before they would do something simple like a biopsy. From the very beginning, she said, how about a biopsy? And they said, oh, no, step medicine. We have to do this, then that, then this, then that, then this. And depending on your insurance, you will see a lot of specialists or you will see no specialists. One of the complaints of emergency room doctors, Dr. Honigman, who was on this office hours, talked about in the emergency room, people would come in and the emergency doc would say, you need this, this, and this, when you leave the emergency. And the patient would say, I can't do it because I can't afford those things. And so here's someone coming in with a problem, know what they need, and they need it now, and they're not able to get it. And they're just going to recycle back into the emergency room with a worsened condition. And that's why the United States, we are #1 in the world for preventable death, meaning deaths that would not occur if we lived in any other country and any other healthcare system. We are #1 in the world for unnecessary morbidities, for worsening conditions that had they been taken care of in a proper way right off the bat. And for instance, people with diabetes, if they could just pop into a clinic, a local clinic every week and, have their insulin levels checked and have a quick once over, 10 minutes, that could save limbs. I remember reading, I was just horrified one year, I think it was 2016, we had something like, I I think it was 7,000 diabetic amputations in the state of California. And some percent of them, I thought like 60, 70%, something like that would be unnecessary. They wouldn't have gotten to that state if they had gotten health care. So think about what that does to someone. You have an amputation, you can't go to work, you lose your health care, you lose your home, you lose your savings, trying to live, right? So everything has multiple consequences to it in this horrible insurance system, which is about stripping every penny possible away from the delivery of care.
So one thing I want to do is kind of connect some dots from the bill to the things that Nancy and Maureen just brought up. So, and actually I can share some things from my perspective. So dermatology is my specialty. So I'm a specialist, and I actually do a mix of procedures and cognitive work, which is true of many other kinds of doctors. It's a mix. And the first thing is that actually, well, I'm not sure that this would be true of all dermatologists. I actually know my pay would go up under this system. That's not really why I'm an advocate for it, but it's just that because one thing I do a lot of in my work is I take care of patients who are on Medi-Cal, and that pays very little. And in fact, that ends up limiting the people who are willing to take it. So it is effectively gives a bunch of people a lack of access to care because they pay so little that they won't, there's nobody who will do that. And so, in fact, plenty of specialists, I think, would see, and primary care people would see it, especially if they in general have focused on the neediest, they will see pay increases. The other thing is that that when you talk about the mix of people who do primary care and specialties, well, what determines that mix? And some of it is the residencies that are available. And residency in the United States is largely funded by Medicare. And that is problematic for a number of reasons. But one thing that CalCare, the bill, very carefully delineates, there's a couple of things that are very relevant to all this. So one is that it knows if we're taking over Medicare, which we would be, the state would be, through a waiver process, that means also taking over the funding of a lot of residencies. And so therefore you can have more of an influence on the primary care specialty mix through that process. Also, there are, well, the bill, so Maureen said something really interesting, which is like, we do very badly on things like having amputations, which is very costly, and obviously costly economically, but devastatingly costly to the individual who's losing a limb, right? Like nothing, I mean, that's the biggest single cost in that should be in that discussion whenever it comes up. And so because of a lack of access to primary care, well, so why is there a lack of access to primary care? Well, so one, maybe not enough people doing primary care. And then the other thing is that primary care does work best when it's near where people live. And so one of the things that the bill can do, and in particular, aware that the accessibility of primary care in our poorest areas of the state, in rural areas, in underserved urban areas, is largely determined by money factors, right? It identifies what's called a special projects budget that says that the CalCare board, and it's the people it designates to help sort of distribute these things, can target extra money to make sure there is a primary care clinic in XYZ neighborhood that hasn't had one, so you could get your glucose checked and get your diabetes managed, and so you don't end up losing your limb, which is a bad thing. So in other words, I want everybody to know that these aren't like, oh, like sometimes people will look and say, oh, well, is this just sort of a magical thing that will somehow solve everything? And I think it will solve a whole lot of problems in our healthcare system, but it's because there's specific details in the bill that envision how that would happen.
You know, Ron, the war on public health started in the 1980s. And by the 1995, all 3 clinics that I worked in had been shuttered. I worked for LA County, and all across the state, public health was being stripped of funding and clinics were closed. And we already had mothers, since it's Mother's Day, we'll talk about that, arriving with 2, 3 little kids, taking, you know, hour and a half on a bus to get to our little clinic, where they waited like all day because we had so many people and so few providers to get care. And we were the best they could do. So once they closed our clinic, what happened to them? Where did they go? What care did they get? You know, I think they just didn't. And part of primary care, there's physician primary care, but we also have, you know, the teamwork of having a nurse can check your insulin and take a look at your toes. And, you know, diabetics need to have a place close by. A lot of them don't walk well, okay? Have to take buses. Transportation is an issue. So we need little clinics. When I was in Spain, just visiting with my sister-in-law's relatives, there were little clinics like everywhere, within walking distance. And she had an elderly aunt who had diabetes and had to walk to get to the clinic, but she walked like 3 blocks. It really wasn't far. You know, they really cared about public health. I wanted to add the statistic I forgot to give with the paper on primary care. And that was that primary care is the only part of healthcare where increased supply is tied to better population health and more equitable outcomes. According to the report, declining primary care workforce capacity is associated with the loss of 85 lives a day in the United States. So that's a pretty interesting statistic. And the fact that Europe has multiple times the number of primary care physicians that we have, and they rely primarily on primary care. So
although there's a comment in that Paul shared with us from Facebook, that's from Dale Berry, that says no one should need to wait for referral or approval. And so the AB 1400 says that there's no, like, any member of CalCare, which is any person who's eligible, which is everybody in California essentially, can go to any provider they want. So it essentially eliminates the need for referrals to specialists. And so that's just a factor, but will have huge impacts on the availability of people who do primary care through the mechanisms we discussed. And well, we also talked about approval for things like procedures. Nancy has your hand up. So
yeah, I have actually a question. You know, in the 90s, I had just started practicing, and it was when the HMOs, IPAs, BPOs just started. I had a close friend who was well invested and made a lot of money. They actually, by moving into a profit-making mode, in my way of thinking, squeezed an awful lot of extra out. Everyone became more efficient, and they made a lot of money in the 90s. People invested in this. And it seems to me that there's a point where you can't just keep making that much extra money because you've already squeezed everybody. And I feel like we've spent 2 decades trying to make that same profit off of healthcare that they made in the 90s. Maybe there was some slack that needed to be tightened. But one thing in relation to another comment, why do you end up getting referred to all these other people and unnecessary procedures? Because we don't have time to have the meetings we used to have. Doctors used to meet regularly and discuss patients at great length. We don't have those times because of all the bean counters. And my question is, we get AB 1400. Are they going to still expect the productivity that so many people are putting out at this level? Or is it going to respect all the professionals on the team and say, okay, we need more time to spend with patients and converse and avoid some of these invasive things or such?
Thank you, Richard. Oh, sorry.
No, go ahead, Ben. It's okay.
Sure. Well, Richard, you kind of asked a question there, but it's not. But also, like, maybe you want to answer it, or I mean, I know I could, but like, but well, okay. Then let me ask Richard, or sort of put Richard's things out there and take a stab at it. So it says, and Richard's a physician, but does everyone understand the approval authorization process? I was chatting with some friends about AB 1400, and they were, thank you, by the way, for doing that. That's a good thing to do. And they were aghast regarding insurance company representatives being able to deny procedures and diagnostics without ever seeing or talking to the patient. And so, and it's actually, that being a thing is very related to what Nancy was just talking about, which is this revolution that was supposed to be something very positive, but I don't think it turned out to be very positive, that hit the ground in the 80s, 70s, 80s, and really took off in the 90s, which is the kind of the abstract term would be utilization management, but it's sort of at the heart of the idea of the health maintenance organization and some other structures of utilization review, which insurance companies use that are akin to it. And so what it is that so healthcare is an expensive thing, right? By, just in any country, it's a big chunk of what national spending is on. And that as technology has become more available, all kinds of things that you're never able to do before are now available in theory if you can afford it. And so, there's some long-term costs to healthcare that are not just systemic, but they're sort of about what's possible. And there's been relentless cost inflation, including after the HMO revolution in healthcare. But the idea was, well, maybe what we need is to institute a bunch of ways to limit healthcare for people who have health insurance, because without those limits, somehow enormous amounts of money will be spent on things that are way more expensive than they need to be, or unnecessary, or et cetera, et cetera. And so what were some of the tools that they developed? Like things like requiring referrals to specialists, requiring approval for procedures and for other kind of like other referrals. Also putting cost sharing mechanisms. So sticking part of the bill on the patient so they become their own denier of care when they may not know whether that's a good deal or not, or a good or bad thing to do, or may not have a choice in the matter because they don't have the cash laying around. And there's a list of things that go on and on. Narrow networks are part of the strategy. There's just like a whole bunch of pieces of these different strategies. But one of them is to allow people essentially by virtue of either having like some rules or guidelines that are in front of them, or almost for just arbitrary reasons, but certainly people who have never ever seen the patient in question, to just deny something for any of a number of reasons. And the experience of certainly of physicians and other people who provide care is sort of an incredible antagonism with these systems. And it's just as infuriating as you'd think it would be, right? Like it's just as mad. It's if like, in other words, your friends who are aghast are right? Their aghastness is right. And the lived experience of fighting these things is hard to describe. Like how, so like something gets denied that you know for sure is, there's no reason to deny it. So then you're like, okay, what am I going to do? So you have to like call some 1-800 number, right? And the first thing that happens when you call the 1-800 number is it's already been disconnected. And then you sort of like look around and you try to find another 1-800 number. And you get that 1-800 number and you call it, and somebody, it's sort of like a call center type employee, let's just say that, which we're all familiar with, right? In fact, that whole call center thing of when there's organizations that don't really want to deal with you has been deliberately adapted to all these purposes, very, very deliberately. You get on the phone, you finally get on the phone after like a phone tree with like multiple options and telling you to hang up if there's an emergency and a bunch of long things. And you get on the phone and you describe a problem. And first, well, you have to like identify the patient's number. You have to identify a whole bunch of things. You might have already keyed them into a thing, automated, but it doesn't matter. You have to identify them again. And then that person won't know what the deal is. And so then other stuff happens, right? And so you might start to like kind of get in a fight or try to explain to them what's going on, but they kind of won't really understand. And so you might say, well, maybe I should talk to somebody who understands this stuff, like a nurse or a doctor or somebody like that. And they're like, oh, okay. Oh, you want like a peer kind of thing. And then they're like, well, okay. Let me put you on hold. I'm going to get one of those people. Okay. So they put you on hold, and then maybe, 10 minutes go by, 20 minutes go by, and then the call is dropped. And then you and then you call again, and you are absolutely at square one on the next time you call. And when you ultimately when you're persistent, although you've ripped this time out of your personal life, out of your lunchtime, you've reduced the number of patients you could see because you have to do this stuff, any of a number of things. You finally get through to somebody, and then there's really good statistics on that 80-90% of the time when you get through, when you lay out all the issues, they're like, they don't know any better than you. So a very high percentage of the time you do end up getting it, but not till it's, especially when it's like questions of like diagnostic procedures and things like that. Usually there's occasionally not, but by then many will have given up or been discouraged, or people by then, patients will have gone and paid for something out of pocket, right? It's all a strategy to shift costs and give people up. I'm sorry, I know this is a long rant on this, but the people who have this experience on the inside will know just how incredibly kind of infuriating it gets. And it's there to train you to not do it, right? It's there to give you such a negative experience so that you'll take on the saying of no on behalf of the insurance company. And that's wrong, and that's what you start to get into Sintal's like kind of moral injury situation, right? People hear about this stuff a little bit, and the same thing happens with medications. It happens with actually often very inexpensive medications in my field. I don't know if you've encountered that, Nancy or Richard, where now just the formularies shift around and things that aren't really that expensive just get denied for no clear reason. So
I often go back and I say, tell me what I can treat this patient with. Just tell me something. And they never have an answer.
No, yeah. And then and they don't know. And yeah.
Or the other thing that infuriates me is I really feel that I've given a big chunk of a medical education for free to whoever's answering the phone. These people who
Yes.
don't know my job, they don't know the diagnoses that I mentioned, and it's craziness.
Yeah, and they're sitting there like reading out some guideline. They're literally in a call center that might include like overseas call center. It's starting to feel a little more like kind of the same runaround when you're trying to, you all know, everybody knows that.
And they go home before 5 o'clock.
I just want to add in another point that when you do that peer-to-peer where you're talking to a physician or nurse, oftentimes they're non-practicing physicians or nurses. So they're not even practicing. And for me, especially for me as a specialist, when I'm calling them asking for a CAT scan or whatever it is, here I am talking to a person who's probably last time they saw a patient was, you know, back in residency or back in medical school or whatever it is, whenever they got their MD. And they're not even a specialist in the field, and yet they're asking me questions. And it's very, the thing that I think is most like hair pulling is I know what questions they're going to ask because they're asking questions off of an algorithm. They have a little booklet that tells them what questions to ask. And I'm telling them, no, you need to get off the booklet. This is a patient's health, and this is what's wrong. And it doesn't fit one of your algorithms, but they need this. And that's one of the big problems. And it's the funny thing is when I talk to other doctors or physicians or whatnot about these issues, the really interesting thing, and it goes to what you're saying, Ron, is that we sort of normalize this behavior. We normalize that this is somehow okay, that this person who has very limited medical experience and very limited medical knowledge is somehow overriding us because that little booklet says so. It's so infuriating.
Yeah, you've all described what I call, well, the process is delay, deny, and hope they die if they need too much from the insurance companies. But it's also the hijacking of your profession. It's been hijacked by people who are practicing medicine without the license to practice it. Because your first failings of people you're going to go through are people sitting at a computer in a little module, right? Who get bonuses for clicking deny. And the other part of that is if you can't click it, you can't give it, right? Because it's all this binary medicine on the computer. So it doesn't deal with the organic reality of what a human being is. And Nancy, I wanted to touch on something you brought up earlier about, you know, having the time and giving away your time. Recent study, well, it was a couple of years ago, I think, was that physicians are giving about, and you're probably giving more, at least 20 hours a week of your time to dealing with these authorizations and dealing with these people sitting in front of a computer practicing medicine without a license, telling you what you can and cannot do. And AB 1400 would, getting rid of these pre-authorizations, getting rid of the insurance industry, would save those 20 hours. And those would become 20 hours of billable patient care, not that free care that you're giving to defend your patients from being destroyed by the system. There was an article in this little paper that was put out by PNHP, and they said that for the about 900,000 physicians that are in this country, 847 million physician hours would be freed up if we get rid of dealing with insurance companies. So those hours, we could go back to having time for, you know, in-services, for having consult time with your colleagues, for having, you know, grand rounds where people could actually take time and stop and have Q&A and discuss things. This could all be returned to the system, because the point of the system would be health outcomes, good health outcomes, and physicians being able to practice their profession. in a way that gives good patient outcomes. And that's not the emphasis now. The emphasis now is only about extraction from the patient, extraction from the doctors, extraction from the facilities, extraction for profit. And that's what we get rid of with AB 1400.
You know, more,
no, well, no, go ahead, Nancy.
I got your comment, Maureen, delay, deny, and hope they die reminds me of Alan Grayson, the US representative from Florida, who got on the floor of the House and said, this is the insurance company's plan. Don't get sick. If you get sick, die quickly.
Yes.
I just want everybody to know that he's looking at an opportunity to run for Senate. And I know he's in Florida, but if you wanted to send $5, it would encourage him to get in there. I think he would be a great asset to the cause.
So let me.
Well, the Republicans do have a plan. I forgot to tell you, it's a new plan. It's called single prayer. That's your healthcare solution.
So, actually, a couple of things that were just said again that, you know, are these just sort of like general rants, or are they like actually about what's in the bill? And the answers are like about what's in the bill. So so for example, Maureen had mentioned that sometimes there's in some places, there are computer systems, so electronic health record systems, that in essence do some of this utilization on behalf of, it's sort of like automated. It's like those little like dogs that are policing, you know, like in some places now, those robot dogs. I mean, and you know, but it's like that the health record itself has a kind of guideline things built in that limit what a provider can do. And AB 1400 isn't super detailed about health record systems, but it says that you can't do that. And the other, you know, the other things is that by, this is one of the interesting things that also goes back to what Nancy was saying about managed care and sort of, so there is a belief or sort of a claim that all these sort of like utilization blocks are necessary to prevent excess money being spent. And it turns out, this is one of the things that was very carefully studied the last time California looked at a single payer bill, SB 562, that when you give everybody health care, you do get some increases in utilization because there was a bunch of people who didn't have access to health care who do now. And that number is, depending how you measure it, it's at least 3.2 million uninsured people in California and way more people underinsured. Even in that. And that means some of those people have needed healthcare for a long time and need to go get it. And so, sure, that's some more utilization. And then among those who have had health insurance, there is all the barriers. They prevent some unnecessary care. It's actually true. They also prevent a bunch of necessary care, which then creates new costs. Then all of the administrative stuff related to all this swamps out all the savings from that. So that when like the big ways that single payer bills and AB 1400 conforms very well as a single payer bill to the way these things have been studied is that they save enormous money on administration, because you can already start to hear about like how many people you need to deal with multiple plans and all these things, right? So there's huge administrative costs that go away, and tied into administration is a bunch of things. And then there's also big savings in pharmaceutical costs, and that comes primarily from the single payer being able to negotiate with pharmaceutical companies, which is an important thing in bringing costs down, and is in the part of the nature of the cost savings in other countries. And the increases or decreases or all those different things in utilization related to the elimination of utilization review is swamped out by the savings from those other things. In other words, the argument for those is quantitatively overwhelmed by the argument against a system that says those things are necessary.
I was going to say, Margaret Flowers said it so well. She said, so who should die in order to keep those profits rising? Who are we going to choose?
We have excess death in our system.
Right. And the other thing that's happened in nursing for a long time, and thank heaven CNA has been fighting it and National Nurses United, is the de-skilling of our profession. And it's happening to physicians too. You're being de-skilled.
Wow, I never heard that before.
Yes,
You're right.
it's called de-skilling. If you can't click it, you can't order it. That's one thing. Some hospitals, the ones without the unions, of course, actually have nurses checking in and out of a room electronically, and they can only allowed to spend so many minutes per room. All right. You walk in a room and your patient is hysterical and crying and just sobbing, right? You want to spend that time with them. You're there to give care, right? You're not a technician. You're there to give care. And to stay with that patient and meet that need is something that will get you a demerit, will get you a problem in some nursing facilities to actually do your job. You're supposed to go in and go out, no matter what is going on with the patient. And that's a de-skilling. And as Ron said, so we're kind of like a little computerized robot, right? We'd like to turn us into robots. And we have to resist that. AB 1400 will help us combat that. Actually, get rid of that.
Mention another profession that I actually think of all of the healthcare professions, the one that suffers the most of the de-skilling that Maureen is talking about is pharmacists. I want to say something about that. So we have, in this state, we have really great high standards and great training for our pharmacists, right? A pharmacist is a doctor in our state. It's the baseline degree is the PharmD, right? Every one of those folks they have like a doctorate, and we really have like a high standards, and they spend all this time like really learning stuff, and they're like potentially incredibly valuable colleagues in making decisions and sorting out issues with patients and helping in the educational efforts and medication, things like that. But in practice, they spend most of their time dealing with coverage matters. And a huge percentage of their time and the time of interactions that we have with this profession that has like so much to offer to the care of patients gets spent instead on these interactions that are like about what's covered or what's not covered. I mean, the number one reason I get a call from a pharmacist, for sure, is about something that's not covered. And then working with them on trying to figure out like what's covered or not covered. So it's like, as frustrating as it is for me, I feel like maybe another way of saying what Maureen was saying is that this bill represents a kind of a revolution in returning to the practice of our healing arts. That's one of the things it offers. Okay. I see a question that came in kind of through the chat, but it was actually messaged to me. So anyhow, so I'll say this question. So the questioner was saying that someone who is concerned about the big brother aspect under single payer of all of our medical info being centralized. And so it's an
we have Big Brother now.
Go ahead. Go ahead. What do you think?
No, that's we have Big Brother now. We already have health systems and health records that are hackable and being hacked. Actually, a system where everything is unified is easier to keep track of. It's also easier to do regulatory administration, to really pay attention to what's going on. Right now, we have something like, I don't know, 1,800 different healthcare plans, and each of those, plans, each of those companies has different sets of records for different people. And we already have Big Brother, not only handling our healthcare records, but deciding what everything we get, we don't get, what our physicians can give us, what they can't give us, what our nurses can do, what they can't do. I mean, it's pretty much a disaster now. So it can only improve.
So, and I'll say with relation to the bill itself, that the bill doesn't mandate a universal health record system. But there would be, there has to be one billing system, and it obviously does need to be secure, but it is currently the case that the kinds of people who have access to your insurance information, which includes like diagnostic codes and things like that, is very large and includes a lot of non-professional people and a lot of people with interest in it currently that aren't, that are not at all working in your interest. So I'll kind of give one example of that, which is that certainly a lot of health plans, and particularly this is a really big problem in the world of Medicare Advantage. So Medicare Advantage are special programs. So people who are eligible for Medicare, which is like senior citizens and some others, can do what's traditional Medicare, but there's some downsides to traditional Medicare, which is it has big cost sharing, and some other downsides. And so there have emerged a program of privatized sort of purveyors of Medicare plans that were sold to the government as ways of controlling costs, and are sold to patients as ways of providing some of the things that Medicare doesn't cover. But one of their big secrets is that they don't save the government money, they cost them more. They spend a lot of money on lobbying to try to keep the whole system afloat. That's a business investment for them, is to lobby to keep that system afloat. But one of the things that they do, there's a couple practices that's very common among them, which is cherry picking and lemon dropping. So what it is, it's a good strategy for one of those companies to get other people to take care of the expensive people, right? So, and in particular, lemon dropping is the idea you look over how much a patient costs from what's been billed, and you use that information to find a way to get them off the plan in one of a bunch of strategies. And so in other words, it's really important for people to know that your healthcare information is being used against you right now, all over the place. There's a bunch of places in the pharmaceutical world where that's also true. So I wouldn't fault anybody who says you have to think really carefully about centralized information systems, right? But nobody should be under the illusion that currently we're in good shape on this stuff.
Yeah, and Ron, one of the problems too is the various insurance companies, I mean, they outsource to IT companies to handle their patient information. And I remember it was about 3 or 4 years ago, a briefcase was found on an airplane, and it was from one of these guys that had millions, and I forgot, like 2.5 million people's healthcare records on his computer, easily accessible in this briefcase that was left on an airplane. I doubt that you would have the state system farmed out to people who could run around on airplanes with 2 million people's healthcare information in their briefcase. That's at least one positive thing, is it'd be easier to keep track of, easier to protect records if they're all in one place. So yeah, I wanted to mention something too. I see Erica put in the chat about politicians enabling this unjust system, being complicit in this unnecessary misery, death, and suffering. I wanted to mention that right now there's a fantastic healthcare activist who's been so busy on so many fronts and really helped out in so many ways. And this person suffers from severe, severe asthma. They've been without a job for a year now, so no longer have their health care. He no longer has his health care. And he is struggling to breathe. Stop for 1 minute and think about what it would feel like to not be able to breathe. Can only walk a few steps and he can't breathe. So his inhalers and his medication prices have all skyrocketed. He's finding it really difficult to pay for what he needs in order to breathe. This is not just a denial of health care. This is a death sentence, but it's also a torture. Think about it. When you look around you, other people have what they need. Other asthmatics have their inhalers. They have their medication. Other people can have it. But you who've worked, 35 years in a system and got furloughed and now can't afford to pay for what you need to breathe, that's what this system does. And I agree with, it was Erica, I think, who put this comment in there. There is a complicity here in not recognizing the serious inhumanity and the serious damage, the torture. It is torture for people to see what they need and not be able to get it while they lose their savings, while their family loses their home, while maybe they even become homeless. Okay? This is a torture. There is no moral justification for allowing this to continue one more day. This is urgent. This is not, one of the other 2,000 bills that the legislature has a look at every year. This is life and death for people. This is an emergency. And speaking of emergency doctors have to figure out where to send a patient, right? And they need to go to a hospital. Sometimes that lapse in time between figuring out where they can send somebody and getting the person there, the patient dies. This happened to a toddler a couple of years ago, a toddler who had to be sent from Martin Luther King to a Kaiser facility. And the delay resulted in the child's death.
Right.
And what happened to the mother? As the mother saw her child becoming increasingly unresponsive, they called the security. She's becoming hysterical. Haul the mother out, away from her 2-year-old, right? As he was dying. This happened just, I believe it was 2 years ago. So this is part of that ugly system of authorization and deciding in this 1800 health plans, like where you can and cannot go, where to send someone or not send them. Those minutes are urgent. It is an emergency. And we have got to let our politicians know this is an emergency for people. And it's not okay to say another year, another time, some other time.
We're at 7 o'clock, and so I want to bring us to a close. There was one more comment that, thank you, Paul, by the way, for passing on the stuff from Facebook. And it was also from Sintal, who we know is a social worker out doing really important work and has been listening. Sin says that also, this is going back to the records thing, that when a hospital is trying to find a placement, the patient's medical records are sent to 30 plus facilities at a time to try to find just one accepting place. Patients' records are already being sent out all over the place. And in all this thing of like, I mean, that's a necessary transfer potentially to someplace, but all of the transfers of, I mean, every single time a patient is transferred from one hospital to another for insurance reasons, is an unconscionable like danger and risk and turnover and place for balls to get dropped and death to happen that is just built into our system right now. So I want to thank everybody who came together on this call on Zoom. I want to thank everybody who listened in on Facebook. I want to really give a great shout out and thanks to Maureen Cruz for years of her advocacy, but her work today on the call and connecting what our system is like and this bill that would change so much.
Thank you, Ron, and everybody on the call. And I'm really glad you didn't say decades, even though it has been. On Mother's Day, let's not age me, Grandma.
I want to give one last plug before we leave too, which is there's a little bit of cost to us doing this. Like we're spending some money on the kind of weekly, just kind of like the social media efforts to promote this and things like that. So I particularly want to encourage people to donate to Healthcare for All Los Angeles, Healthcare for All Los Angeles. If this has been valuable and if you can give a few bucks or several bucks or several, tens or dozens of bucks to Healthcare for All Los Angeles to help us keep going, because we're doing this every week and we want to make sure that we can sustain it and keep putting the word out that this is happening and bring new thoughts into the process, new questions. There were like fantastic questions and issues that were brought up today. So is anybody able, what I didn't do is thank you. There's a link, healthcareforalla.org/WP/donation. Can we throw that onto Facebook too? Can we is that already done?
I did it already.
All right. And I would be so grateful for people to who taken part or others to just, if they throw in a little bit, they'll help us keep going because we're not stopping. We're going to stop. We're not going to stop. Yeah. So the bill's passed. So, all right, we're past our time. Maureen, any last?
I just want to thank everybody who's on the call, everybody who's on Facebook, everybody who cares about your fellow human being, for everybody for whom it matters that we all have the same opportunity to thrive. Thank you all for caring, because that's the crux of the system we want. We want to put the care back into healthcare. It's not there right now. It's there on the provider level. It is not there in the system. And we have to change it to a system of caring.
All right. Have a good evening, everybody. Happy Mother's Day.
Thank you. Thank you, Ron. Thank you, Paul. Thank you, everybody. Thanks,
Bye
Nancy,
now.
Carol, Dennis, Erica, Steve, Carolyn, everybody. Bye.
In the end, bye.